Welcome to the deep dive. You know, sometimes you come across a term that pops up in health discussions and you think, okay, what's the real deal here? Today, we're doing exactly that with raised intraocular pressure, or IOP. Think of this as your shortcut to understanding why this little pressure reading is actually, well, a pretty big deal when it comes to your eyes.
Absolutely. Elevated IOP isn't just a random number. It's a key player in the story of glaucoma, which, as many know, is a leading cause of irreversible blindness. So understanding what influences this pressure and what it means is truly about taking proactive steps for your long-term vision.
Exactly. Whether you've seen IOP on a medical note, maybe your eye doctor's brought it up, or you're just naturally curious about how your eyes work, we're here to shed some light on it. And hopefully without getting bogged down in really complicated medical speak. Our goal today is to unpack this from the ground up, covering everything from what it is to what happens if it's not looked after.
Yeah, we'll be taking a systematic approach. We'll look at the definition of raised IOP, dive into its potential causes, identify who might be more susceptible, understand how it develops. Consider what else it could indicate, look at how common it is, how it might or more often might not present itself, then how it's diagnosed, the current ways it's managed, what the future of treatment might look like, and crucially, the potential problems if it's ignored.
Okay, let's get right to it then. What exactly is raised intraocular pressure?
In the simplest terms, raised intraocular pressure is just an increase in the pressure inside your eye. Now, when we say inside, we're primarily talking about the anterior chamber, that's the fluid-filled space at the very front of your eye, sort of between the cornea and the iris and lens.
Okay.
The normal range for this pressure is generally considered to be between 10 and 21 millimeters of mercury. You might see that written as mmHg.
Oh,
Think of mmHg as just a standard unit for measuring pressure. It gives us a specific way to track your IOP over time.
and why does that number matter so much? What's the critical link we need to remember here?
The critical link, is to glaucoma. Now, it's important to say not everyone with elevated IOP will go on to develop glaucoma, but it's one of the most significant risk factors.
Oh, okay.
Think of it maybe like the pressure in a car tire. If it's too high for too long, it can strain the tire walls and eventually cause damage. Similarly, persistently high IOP can put pressure on the delicate optic nerve, which sits at the back of your eye.
Right.
This nerve is basically what carries all the visual information to your brain, and damage to it is, well, that's the hallmark of glaucoma.
So what are the things that can actually cause this pressure to go up in the first place? What's throwing off the balance inside the eye?
The primary reason for raised IOP is usually an imbalance between the production and the drainage of the eye's natural fluid. It's called the aqueous humor.
Aqueous humor, right?
This fluid is constantly being produced by a structure behind the iris. It then flows through the front of the eye before draining out through a kind of meshwork system right at the angle where the iris and cornea meet.
Okay, like a little drain.
Exactly. So if too much aqueous humor is produced, or if that drainage system isn't working efficiently, the fluid starts to build up, and naturally the pressure inside the eye increases.
Are there specific conditions or, situations that can lead to this kind of imbalance?
Yes, there are several. Some are directly related to the eye itself, like primary open-angle glaucoma. In that case, the drainage angle is open, but the outflow is still reduced somehow. Then there's angle closure glaucoma, where the drainage angle actually becomes blocked, physically blocked.
Okay, that sounds more sudden.
It can be, yes. Steroid-induced glaucoma is another important one to know about. Long-term use of steroid medications, even things like eye drops for other conditions or inhalers or tablets can sometimes raise IOP.
Really? Even steroid eye drops?
Yes, potentially. Then there's a condition called ocular hypertension. That's where the IOP is high. But currently, there are no signs of optic nerve damage or vision loss. It's just the high pressure itself.
So high pressure, but no damage.
Yeah, precisely. And finally, other eye diseases or even some systemic health conditions can also contribute to elevated IOP.
Okay, so it's not always a simple single cause. That makes sense. Now, who tends to be more at risk for developing raised IOP? Are there certain factors that make someone more susceptible?
Absolutely. Several risk factors have been identified. Older age is a significant one.
Yeah.
As we age, the eye's drainage system can just become less efficient over time.
Right.
A family history of glaucoma also definitely increases your risk, which suggests there's a genetic component involved. Certain ethnicities also have a higher prevalence of glaucoma and ocular hypertension. This includes individuals of African, Hispanic, and Asian descent. The exact reasons for this are complex, still being researched, but the link is there.
Okay.
A history of eye injury or previous eye surgery can also impact the eye's fluid dynamics and potentially raise pressure. Long-term use of corticosteroid medications, as we mentioned, is a well-known risk.
Yeah, the steroids again.
And certain other health conditions like diabetes, for example,
Mm-hmm.
and even specific anatomical features of the eye itself can play a role. Some people just have narrower drainage angles naturally.
Wow, okay. That gives us a much clearer picture of who might need to be perhaps extra vigilant.
Mm-hmm.
So we know the pressure goes up because of this fluid imbalance, but how exactly does that increased pressure then lead to damage? What's the sort of step-by-step process happening inside?
Well, think back to our analogy of the overfilled sink, maybe. If the aqueous humor can't drain properly, the increased fluid volume raises the pressure inside that closed space of the eye.
Right.
This elevated pressure can then start to exert a mechanical force, a physical stress on the very delicate nerve fibers of the optic nerve.
These are the fibers carrying the signal to the brain.
Exactly. They're like tiny, fragile wires bundled together, carrying all those visual signals. Over time, this constant pressure can damage these fibers. Initially, you probably wouldn't notice any change at all. But as more and more fibers become damaged, it can lead to the development of blind spots, usually starting in your peripheral or side vision.
Peripheral vision, okay.
And if it's left unaddressed, this damage can unfortunately progress, leading to significant and crucially irreversible vision loss.
It's like a gradual wearing down of those critical connections then. It sounds quite insidious because it's happening slowly.
It really is. That's why early detection is key.
Now, if someone has raised IOP, is it always like a guarantee that they have glaucoma? Or could there be other explanations for just that high reading on its own?
That's a very, very important point to clarify. Raised IOP is a significant risk factor for glaucoma, definitely. But it's not the only factor, and it absolutely does not automatically mean someone has the disease.
Okay, good to know.
That's where the differential diagnosis comes in. We need to consider other possibilities. As we mentioned, different types of glaucoma, open angle, angle closure are primary considerations, of course.
Mm-hmm.
But we also have ocular hypertension, which we define as high IOP without current optic nerve damage or vision loss. That needs to be distinguished.
Right.
Then there are other conditions like pseudoexfoliation syndrome. This involves a buildup of tiny, flaky material inside the eye that can actually clog the drainage angle.
Like debris blocking the drain.
Pretty much, yes. And uveitis, which is inflammation inside the eye, can also cause elevated IOP temporarily or sometimes chronically. Even certain medications or other temporary issues can cause pressure spikes.
So a high IOP reading really means a thorough checkup is needed to pinpoint the real cause.
Exactly. It's about piecing together the whole picture: the pressure reading, the optic nerve appearance, the visual field test, the drainage angle examination to get the right diagnosis.
Okay. How common are raised IOP and these related conditions, thinking specifically here in the UK?
Well, in the UK, glaucoma itself, encompassing both primary open angle and angle closure forms, affects roughly 2% of individuals over the age of 40.
2%. Okay.
Ocular hypertension, just the high pressure without damage, is estimated to be even more common. It affects around 4 to 7% of people in that same over 40 age group.
Wow, 4 to 7%. That's quite a chunk of the population.
It is. These figures really highlight that raised IOP and its associated conditions are relatively prevalent, especially as we get older. It really underscores the importance of regular eye health checks.
Absolutely. But what might someone actually experience if they have raised IOP? Are there noticeable symptoms that would prompt them to see a doctor early on?
This is one of the trickiest aspects, actually, because in the early stages, raised IOP is typically completely asymptomatic.
Meaning no symptoms at all.
Correct. People usually don't feel any difference in their eyes or notice any change in their vision. This silent progression is precisely why regular eye exams are so crucial for picking it up early.
Right, the silent nature.
Now, as the pressure increases significantly, perhaps quite rapidly in some cases like angle closure, some individuals might start to experience nonspecific symptoms. Things like blurred vision, maybe some eye pain, headaches, seeing halos or rainbows around lights, or even just redness of the eye.
But those sound like they could be anything.
Exactly. They're very nonspecific. They can be associated with many other eye conditions, so they aren't reliable indicators of raised IOP on their own. You can't rely on symptoms appearing.
And specifically for ocular hypertension, that category of high pressure, but no current damage. Are there any telltale signs for that?
No, by definition, ocular hypertension doesn't present with any noticeable symptoms either. It's characterized solely by that consistently high IOP measurement, over 21 mmHg, in the absence of any detectable damage to the optic nerve or loss of visual field. And crucially, without any other underlying eye conditions that could be temporarily raising the pressure. It's purely a silent risk factor.
Which is why it often gets picked up during just a routine eye examination, I suppose?
Precisely. Often an incidental finding during a regular checkup.
Okay, so if a doctor suspects raised IOP, maybe from a routine check or because of risk factors, what kind of tests are involved in figuring out exactly what's going on?
Several key investigations are essential. The most fundamental is tonometry. That's the actual measurement of the intraocular pressure itself.
Tonometry, okay.
A helpful mnemonic here could be to think tone. The pressure we need to know the tone or level of pressure inside the eye.
Got it. Tone the pressure.
Then, very importantly, we need to examine the optic nerve for any signs of damage. This can be done through ophthalmoscopy, where the doctor looks directly at the back of your eye using special lenses and lights.
Right.
Or, increasingly common now, with advanced imaging techniques like optical coherence tomography, usually called OCT. OCT provides incredibly detailed cross-sectional images of the optic nerve head and the nerve fiber layer.
Like a detailed scan.
Exactly. Visual field testing is also crucial. This maps out your peripheral vision very carefully to identify any early blind spots or areas of vision loss that you might not even be aware of subjectively.
Testing the edges of your vision.
Precisely. Gonioscopy is another important test. Here, a special mirrored lens is placed gently on the eye to allow the doctor to directly examine the drainage angle, that area where the fluid is supposed to leave the eye. We need to see if it's open and functioning correctly or if it's narrowed or blocked.
Gonioscopy. Checking where the fluid should go.
Good way to remember it. Gonio. Where does it go? And finally, measuring the thickness of the cornea with pachymetry is important too.
Why the cornea thickness?
Because the thickness of your cornea can actually influence the IOP reading obtained by some tonometers. A thicker cornea might give a falsely high reading, and a thinner one a falsely low reading. So knowing the corneal thickness helps us interpret the IOP measurement more accurately.
Ah, okay, so it adjusts the reading. Are there specific guidelines, perhaps from NICE, on which tests are recommended for these situations?
Yes. The National Institute for Health and Care Excellence, NCE, provides clear recommendations for assessing suspected open-angle glaucoma and ocular hypertension. These generally include Goldman applanation tonometry as the sort of gold standard for IOP measurement, corneal thickness measurement with pachymetry, gonioscopy to evaluate the drainage angle properly, standard automated perimetry for detailed visual field testing, and a thorough examination of the optic nerve head and the fundus, the back of the eye, using a slit lamp microscope.
So a really comprehensive workup.
Yes, it ensures all the key aspects are assessed to get a clear understanding of the situation and the level of risk.
Right, a thorough set of tools to understand what's happening. So moving on, if raised IOP is diagnosed, perhaps as ocular hypertension or as part of glaucoma, what are the ways it can be managed? What are the main treatment options?
The management strategy is really tailored to the underlying cause and, importantly, the individual's overall risk profile. How high is the pressure? What does the optic nerve look like? What are their other risk factors? If it's linked to a specific medication, like steroids, for instance, then obviously stopping or changing that medication, if possible, might be the first step.
Makes sense.
However, for managing the elevated IOP itself, the mainstays of treatment are usually medication, primarily in the form of topical eye drops, sometimes laser therapy, and in certain cases, surgical interventions.
Okay, let's talk about those medications first. What kind of eye drops are typically used?
There are several different classes of eye drops, and they work in various ways to lower IOP. Probably the most commonly used first-line agents are the prostaglandin analogs, like latanoprost. These mainly work by increasing the outflow of that aqueous humor from the eye.
Increasing the drainage.
Exactly. Then you have beta blockers, such as timolol. These work differently. They help to reduce the production of aqueous humor in the first place.
So less fluid being made.
Correct. Carbonic anhydrase inhibitors, like dorzolamide, also work primarily by decreasing fluid production. Sympathomimetics, such as aproclonidine or brimonidine, can have a dual effect. They can both decrease production and potentially increase outflow slightly. And then there are miotics like pilocarpine, which aren't used as often now, but work by constricting the pupil and helping to physically open up the drainage angle meshwork.
Wow, quite a range of mechanisms.
Yes, And each class has its own potential side effects, both local in the eye and sometimes systemic if absorbed into the bloodstream. So the ophthalmologist will discuss these with you to determine the most appropriate and best tolerated option, or sometimes a combination is needed.
And what about laser therapy and surgery? When do those come into play?
Laser trabeculoplasty is a common laser procedure, particularly for open-angle glaucoma. It uses a laser to basically stimulate the trabecular meshwork, that drainage system, to function better and improve fluid outflow. It can be very effective.
So tweaking the natural drain.
Sort of, yes. Surgical options, like the traditional trabeculectomy or newer, minimally invasive glaucoma surgery techniques known as MIGS, involve creating new pathways or channels for the fluid to leave the eye and thereby lower the pressure. These are typically considered when eye drops and laser therapy aren't sufficient to control the IOP to the target level, or perhaps if the glaucoma is more advanced or progressing rapidly.
Okay. And I assume regular monitoring is key after any treatment.
Absolutely essential. Regular follow-up appointments are needed to check the IOP, monitor the optic nerve and visual fields, and ensure the treatment is working effectively and safely over the long term. Adjustments might be needed over time.
Now, what if someone is diagnosed just with ocular hypertension, that high pressure, but no signs of actual glaucoma damage yet? Does that always need treatment with drops or lasers?
Not necessarily, no. In cases of isolated ocular hypertension, especially if the pressure isn't extremely high and the person doesn't have many other significant risk factors, a strategy of careful observation and regular monitoring might be adopted instead of starting treatment immediately.
So just keeping a close eye on it.
Yes. The decision to start treatment depends on weighing up several factors: the actual level of IOP, the individual's age, their corneal thickness, their family history, the appearance of the optic disc, and any other risk factors for developing glaucoma. It's a personalized risk assessment.
Right.
Generally speaking, laser and surgical interventions are used not the first-line treatment recommended for ocular hypertension alone. They're typically reserved for when there's clear evidence of glaucoma developing or progressing.
That makes sense. Before we move on, are there any practical tips for people who are using eye drops? Things they can do to make sure they're as effective as possible and maybe minimize any potential side effects?
Yes, definitely. Firstly, consistency is paramount. Using the drops exactly as prescribed every day is crucial for keeping the pressure controlled. Setting reminders can help. To help with actually getting the drops in, especially if someone finds it tricky with dexterity or aiming, using an eye drop dispenser aid can be really helpful. Your pharmacist can advise on those.
Good tip.
After putting the drops in, a technique called punctal occlusion is highly recommended. This involves gently pressing on the inner corner of your eye near your nose for a minute or two immediately after instilling the drop.
Punctal occlusion, what does that do?
It helps to block the tear duct temporarily. This reduces the amount of medication that drains away from the eye and gets absorbed into the systemic circulation through the nasal lining. So it keeps more drug in the eye where it's needed and minimizes potential side effects elsewhere in the body, like effects on heart rate with beta blockers, for example.
Ah, very useful technique.
Yes. And finally, simply blotting away any excess drops that might spill onto the eyelid or cheek with a clean tissue can help prevent skin irritation around the eye.
Those are really useful practical steps. Thank you. So thinking longer term, what's the overall outlook for someone who's been diagnosed with raised IOP? What's the general prognosis like?
The prognosis really depends heavily on the underlying cause of the raised IOP and, critically, how effectively the chosen treatment can control the pressure and prevent or slow down optic nerve damage. The good news is that with early detection and appropriate, consistent management, it's often possible to significantly slow down, or in many cases even prevent, the progression of optic nerve damage and the associated vision loss from glaucoma.
So early action makes a big difference.
A huge difference. The key factors for good prognosis are really the patient's adherence, sticking carefully to their prescribed treatment plan, and attending regular follow-up appointments with their eye care team for monitoring.
Right, compliance and follow-up. And flipping that coin, what are the potential consequences if raised IOP isn't properly managed or detected late? What are the serious complications we need to be aware of?
Well, the most significant complications of uncontrolled, persistently raised IOP are, unfortunately, progressive and irreversible damage to the optic nerve. This leads to the gradual loss of visual field, often starting peripherally, as we discussed, but potentially progressing towards central vision impairment.
which can lead to blindness.
Yes, ultimately, it can result in significant glaucoma-related vision impairment and, in severe, untreated, or poorly controlled cases, legal blindness. And because the damage to the optic nerve fibers is generally considered irreversible once it's occurred, early detection and consistent treatment are absolutely crucial to prevent these potentially devastating outcomes.
Prevention is definitely key here then.
Yeah.
So to try and bring all this together, what are the absolute key things you want our listeners to really take away from our deep dive into raised intraocular pressure today?
I think the essential points to remember are, firstly, that raised IOP is a major identifiable risk factor for glaucoma, which is a serious condition that can lead to irreversible blindness if left unchecked.
Okay, number one, risk factor for glaucoma.
Secondly, it's often silent, completely asymptomatic, especially in its early stages. This makes regular, comprehensive eye exams incredibly important for detection, particularly for those over 40 or with other risk factors.
Number two, often silent, so get checked.
Thirdly, accurate diagnosis isn't just about the pressure reading. It involves several key tests to assess the optic nerve, visual field, and drainage angle to understand the full picture.
Right, diagnosis needs the whole picture.
And finally, management is tailored to the individual. The goal is always to lower the pressure effectively to protect the optic nerve and preserve vision long term, and adherence to treatment is vital for success.
Perfect summary. Be aware of the risk, get checked regularly because it's often silent, diagnosis is comprehensive, and treatment needs consistency.
Exactly. It really comes down to being proactive about your eye health.
It really does. And it makes you think, doesn't it? Considering how often raised IOP progresses without any noticeable symptoms, it really prompts the question for everyone listening. What proactive steps can you take to make your long-term eye health a priority, even if you feel like your vision is perfectly fine right now?
A very important question to consider.
For more resources to help you master topics like this for your MSRA, head over to pastthemsra.com.
And for free study materials and support, be sure to check out framesra.com.